Hey, I am Dr. Dan Kalish, and welcome to our fall mentorship mini series. Mini series on brain health. This is, I don't know, I think the most interesting topic possible in functional medicine. So I'm glad you are joining for this call. My goal for today is to make this impactful and to make you think about things and to learn something new that you can use with your patients right away that's completely effective, that actually works. There's a lot of new people that have signed up for this class, so I'm going to introduce myself. We have these free mini series that we do, every season. This is the fall version of it. And it's called the Mentorship Mini Series because we do these right before we start a new group for my mentorship program. And uh, we have really great group of doctors in the classes right now. So if you guys are interested in signing up, this is a great time to do the entire year-long mentorship. I've been in practice for 31 years. I founded the Kalish Institute back in 2006. We've trained thousands and thousands of practitioners now in lab interpretation skills, patient communication skills, program design. It's kind of what I do. I've worked with the Mayo Clinic on a research project. We studied the Kalish method, published that. I've worked, and in fact, I just spoke today for a couple hours with Dr. Richard Lord. So Richard's the scientist that first did organic acids, amino acids, fatty acids, and the GI effects. Most of the really amazing testing that we all use every day in our practices came from the lab of Richard S. Lord. And I don't know, he's not a friend, is he a mentor? I don't know what he is. He's just someone that I love deeply, who has changed my life profoundly and has taught me so much about lab interpretation. Even today on the call, we were just kind of catching up. And after we talked about his new kayak that he just bought, he started laying into me about lab interpretation and fatty acids and this and that. And he just can't help but teach me things with the goal of me then turning around and teaching other people. So Richard, as one Kara Fitzgerald once said, is a national treasure. And one of my roles on the planet right now is to help preserve his knowledge and to pass it on. So if you want to become a certified practitioner, we have our mentorship program, and that's going to be starting September 16th. The fall group is always our most lively and fun group. So if you want to join, you should join. You can scan that QR code and you'll get a hefty discount there, okay? And if you've been thinking about it for a while, just sign up. Nobody ever regrets signing up for this class, I'll tell you that. It's a really great group of people. You're going to learn a ton of information and be able to implement, functional medicine protocols. So what we're going to do today is like a mini class because we don't have that much time, but I really want you to be able to impact people by learning how to use amino acids. And there's really 4 that you need to become familiar with. And you need to use these like you know how to use a kitchen knife for cooking, right? It just should be something that is just, you do it every day, you know how to do it, you're really good at it, you can make it work, okay? It's a skill you just need to acquire. Tyrosine and mucuna are 2 of them. Tryptophan and 5-HTP are the other 2. So you learn how to use those 4. I'll say them again, tyrosine and mucuna. Mucuna is a herbal form of L-DOPA, for those of you that don't know. And tryptophan and 5-HTP. You just learn how to use those 4 products in different combinations, and you can impact all whatever 180 neurotransmitters with those 4 products just by looking at it in terms of systems, like a catecholamine or dopamine system, and then a serotonin system. Okay, and it's not, well, I was going to say it's not that complicated. It's really complicated, and so it takes a little while to figure it out. But it's only 4 products, to be on look on the bright side, right? So if you just figure out how to do dopamine alone, that's going to be 90% of this. So we're going to talk a lot about dopamine and how to support the low dopamine patient and how low dopamine ties back to detoxification pathways. So it's the exact same nutrients that are required as cofactors to make dopamine as are used to run detox pathways and protect your brain. So when people have a nutrient deficit of something like cysteine, or other sulfur amino acids or B vitamins like B6, you're going to have trouble both making adequate amounts of dopamine and getting rid of the neurotoxins that damage dopamine neurons. So that's convenient from our perspective because you can fix low dopamine and get detoxification pathways working better at the same time with the exact same nutrients. But it's bad for patients because if you have a environmental toxin exposure, which we all do, right, and you have low dopamine, then that kind of cascades in a really negative way. You stack on top of that genetic issues. A lot of our patients can't make adequate tyrosine. You make tyrosine from phenylalanine. Obviously, you eat it too in your food, but you make a lot of it from phenylalanine. Some people just can't do that very well. Some people have drunk a lot of alcohol. That's going to screw this whole system up. Head injuries, there's all kinds of reasons why people can have problems here. And of all the things that I've learned in functional medicine, mastering the treatment of dopamine, I think has probably led to the biggest relief of human suffering in the patients that I've worked with. So it's a really important skill set, okay? Conditions related to this, weight loss, because when your dopamine's messed up, you overeat. Energy, because obviously catecholamines, and we kind of group these together, right? So epinephrine, norepinephrine, and dopamine. The treatments are identical. So energy, depression, mood, people have trouble with attention and focus and concentration. We just had a case yesterday in the mentorship, shaking, restless leg cases, stuff like that. People who have addictive issues with drugs and alcohol. We get all kinds of college students now that are hooked on all these Ritalin type drugs, that kind of stuff really causes dopamine related problems. So you see dopamine, dopamine issues manifest in a lot of different people. Tired, toxic, catabolic, stressed, whatever it may be. And I group this into 3 different groupings, and the treatments are a little bit different. So you kind of, over time, need to figure this one out. Is there a neurotransmitter deficiency? That's the easiest one. That means the person was stressed for a long time, so they burned out their neurotransmitters. Everyone's been through that. They had a poor diet, or they have GI issues. They didn't absorb the amino acids that they needed to make the neurotransmitters, right? That could happen too. You could have somebody that has a drug depletion. They were on an SSRI for 15 years and they never put things back together again after that. That could be another version of that. And so deficiency states are the easiest because you give the person the tyrosine and mucuna, they feel better. They can stop taking the tyrosine and mucuna. They still feel better because there was a deficiency, you made up for it, and now they're better. That would be like, I don't know, if you're, let's think of a good example. It's not really like eating. It's more like if, yeah, like in the latch in my car, it just was stuck. I just couldn't get this thing to open. So we put some, TriFlow, WD-40 type stuff on it. Now it works fine. So it wasn't lubricated. Now it's lubricated. Now it works. That's it. So neurotransmitter deficiency states, assuming the person is not stressed, assuming you fix their diet, assuming you fix their GI tract, assuming they're not on the drugs anymore, you just get them working again, and that's it. It's over, and the rest of their life they're going to feel better until they develop another problem, like they're stressed or they have GI issues or whatever. So these are neurotransmitter problems that are really derivative of stress, poor diet, GI issues, drug depletion. Very straightforward, easy to treat. Those people get better fast. They will love you. You will love them because it's easy to fix, and it's just done. Okay, so that's one category. Second category, damaged neurons. This is not so easy to correct because now we're talking about neurotoxins or physical trauma, blows to the head, that have damaged neurons. So now the neurons aren't working right. This is not a deficiency state. The actual structure of the neurons are damaged. They're physically damaged. Some of them are dead. They're gone. Dead and gone, okay? This is a little more serious because you got to get the ones that are remaining to fire properly. It's harder to correct this. And it's very common for people to have neurotoxins or physical trauma. Physical trauma would be any kind of a head injury. You hit your head in a car accident, you had a whiplash injury, you were in Iraq for 2 tours and you got blown up in a Humvee, you fell off a horse, you got hit by a baseball bat, whatever it is. Football players, I mean, I would say probably almost every football player that you can imagine who actually plays football is going to have, multiple physical traumas, blows to the head. So you're going to see this in a lot of different people. Kickboxers, I've had professional ski jumpers, anyone whose, job involves their head getting banged around, okay, is potentially going to be on the damaged neuron list. And then anyone who has any kind of environmental toxin that's a neurotoxin. Could be mercury, lead, could be anything. And then on top of all that, there are the genetic factors, right? Which would just exacerbate all three of these things. So, and you can detect several genetic patterns on these tests that we're about to look at. Like, for example, people that don't convert phenylalanine to tyrosine, that's a genetic issue. Right? And if you know that, then you just give the person extra tyrosine and they get better. It's that simple. The treatments for each of these different imbalances is the same. If they have a deficiency, you give the tyrosine, the deficiency is gone, now they're better. If they have damaged neurons and the dopamine neurons are not working well, you still use tyrosine and mucuna to get them working right. But obviously that may take a longer period of time, or they may need to be on these products for even a couple of years. If there's genetic factors, you can't fix the genes, right? So they may have a longer term need for the nutrients. So the nutrients that are solving these problems are the same, but knowing if it's a deficiency versus damaged neurons versus genetic factors makes a big difference. Okay, now I want to just do something. We're going to go away from the slides for a second because I just want to prove this point, show this point here. And I was looking at these labs earlier and I thought, oh, I should tell them this. So I just want to show you just real quick here. Oh, well, this was a good one to choose here. So this is a NutrEval from Genova. And here are the catecholamine markers. Homovanillinic is very low. DL means underneath the detected limit, okay? Vanilmandelic is a little high. So homovanillinic acid is a metabolite of dopamine. So when that marker is low, there's a low dopamine state. Vanilmandelic is from epinephrine, norepinephrine. When that marker is high, there's an overproduction of those catecholamines. Or not an overproduction, I say overmetabolism. They're being broken down too rapidly. Okay, so there's an imbalance there. So all that being said, okay, there's a problem with the neurotransmitters themselves. But let's cut down and look at here, because this test also has the amino acids. And now you can see in this example, and the amino acid that we're going to focus in on here is tyrosine, because that's the one that you make all these from. And you can see the tyrosine levels are borderline low. That's a nutrient deficiency state, okay? It could be caused by a genetic issue. It may be that they don't convert phenylalanine to tyrosine very well. It could be caused by stress, could be caused by a lot of different things. But when you see a nutrient like an amino acid that's low, there's obviously a nutrient deficit state. You replace that, the person gets better. Tyrosine is the solution. Separately from that, but in the same brain, right? This is the same person here. Separately from that, the homovanillinic acid is extremely low. It was so low, the lab couldn't even detect it. That's really low. Okay, that's like extra low. It's like they have extra small shirts or extra large. That's just like extra small or something. They couldn't even find it, all right? That's really low. So homovanillinic being low, that's dopamine levels not being there. The tyrosine being low is the amino acid itself. Okay, so you're measuring these things in different ways. Sometimes people have this marker low, but the tyrosine levels are fine. Sometimes people have the tyrosine levels low, but this marker is fine. Okay, you got to be able to look at this from two different directions. So I just want to point that out. It's very confusing on the labs. I'm going to say this one more time. This is a dopamine marker. It's low. The tyrosine is a little low also. So this person has both low tyrosine and low dopamine metabolites. That makes sense. But you could have a patient that just has this low and the tyrosine is fine, or that has low tyrosine, but this is fine. In all of these cases that I'm talking about, the treatments are the same. You use tyrosine, but it's a little confusing. So I just wanted to point that out as we develop lab interpretation skills. So you also need to know how to use tyrosine, and I'll cut to the chase. The standard adult dose, if one of these markers is positive, is 1,000 milligrams of tyrosine with breakfast, with lunch, and with dinner. Okay, with breakfast, with lunch, and with dinner. With breakfast, with lunch, and with dinner. You can do them on an empty stomach, but I think it works better. It's easier for patients. And it's more a graduated sort of rise in dopamine if you give the tyrosine with food. You can do it on empty stomach, but that's going to raise dopamine levels faster. And sometimes that's not a good thing because they may decline faster too. So I think with meals for these specific amino acids for the brain is better. You can do it on an empty stomach. There's some ways that we use amino acids where empty stomach is absolutely required, but this is one where you could do it either way, but easier with meals. You can also use mucuna. And mucuna is a plant form of L-dopa, but it's standardized to have a certain amount of L-dopa in it, depending on what brand you use. So mucuna is really an amazing thing. For people that are low in dopamine, mucuna is significantly life-changing, okay? And then there's certain nutrients that you have to make the tyrosine or mucuna work, including sulfur compounds like methionine or cysteine, B6, and folate. In fact, you could give all the tyrosine in the world, and if the person doesn't have enough B6, you're not going to improve brain chemistry. Okay, so the cofactors like B6, these sort of ancillary nutrients that go along to help you make these brain chemicals, they're not optional. They have to be there or the whole thing doesn't work. Okay, and then you have amino acids like glycine and cysteine that, again, are related to both brain chemical production, and you'll probably recognize they're also related to detoxification. So you have to kind of assess detoxification pathways in every patient that has a brain problem, because if both those things are existing, which they often do exist together, you want to treat them at the same time, but it's the same product, so you don't have to worry about that. But you need to know that, okay? And we can show those. I'll show you those markers in a minute when we look at more testing. And then there's also the competition of methylation and glutathione, and that can really screw things up too. So the way around that is just to give everybody a B complex. I mean, that's kind of cheating, but if you give everybody a good quality B complex and some N-acetylcysteine, you take care of 90% of these problems. Okay, so let me just say that again. If you give every one of these patients a single B complex, once a day, along with, let's say, at least 3,000 milligrams of N-acetylcysteine, or you could do 3,000 milligrams of glycine or methionine, but usually people use NAC, then you'll take care of a lot of these detox / production / B vitamins / cofactor issues. If you don't use the NAC and the extra B vitamins, probably cut the odds in the program back from working by at least 50%, something like that. It still could work for some people, but it's not going to be consistent, okay? And then we want to understand when to use each of these products. So the easy way to say it is start with everybody on tyrosine that has a dopamine issue, 1,000 milligrams 3 times a day. Give them 1 or 2 weeks. If you're not seeing any kind of response, then consider escalating by adding in a mucuna product. And remember this relationship between neurotoxins and dopamine I keep talking about, because as soon as you see dopamine markers that are messed up, you want to go right over and look at the detox markers. So like with this person here, they had the dopamine problem, yeah? And then let's look down here and the main protector of the brain is glutathione. And glutathione in this patient is low. So I'm not saying that I watched the TV series Vikings and really enjoyed it, especially when the Vikings attacked Paris. I thought that was really just kind of a whole amazing time in history, and it was kind of cool to see it. But if I had watched the Viking series, and I encourage all of you to watch it, they do the shield wall thing. So anyone who's seen Vikings is knowing what I talk about. The main king guy goes shield wall, and then all the guys that are about to kill all the other Vikings in the other army, they put their shield up, right? And then when the arrows are coming in and it hits the shields and no one dies, where like a few guys die, but not a lot of guys die. So shield wall, like okay. So the shield wall for your brain, the thing that protects you from the arrows and the spears, is glutathione. So glutathione is the master antioxidant. And shield wall, the arrows coming in at us are like mercury molecule in your brain, diesel exhaust in your brain, benzene, toluene, any kind of fat soluble thing that can get into your brain. What's protecting that damage to your dopamine neurons is glutathione. So if glutathione levels are low, you are in some serious trouble. You have lost your shield wall. It would be like the Viking movie or TV series, right, where the two armies are facing off and the guy yells shield wall and the guys are like, what did he mean? And their shields are not up and then the arrows start coming in and they all get hit. That's kind of what's happening to this person on this lab. No shield wall, no protection. If you like Star Trek more, remember in Star Trek, they had the whole thing too where they would say, shields up or something like that, but before the like photon torpedoes would hit. This is the protector. If this is low, this whole problem that we're talking about with neurotoxins is, it's inevitable. It's inevitable. This is what's protecting your brain from the damage of neurotoxins. We're all exposed to neurotoxins every day because we have a very toxic environment that we've created on this planet. So this being messed up, now your dopamine neurons are not protected. So what's going to happen, you're going to go over to this part of the lab here, and you're going to see that there's a big dopamine problem. So these are not just related. These are really the same thing, okay? Low dopamine, low glutathione connected, okay? And you have to fix them in a unified way. How? NAC and glycine, 3 grams of NAC, 3 grams of glycine. That'll get your glutathione levels up. But remember, you can also use those NAC and glycine supplements for helping production of dopamine. You give B complex. B complex is required to make the whole glutathione methylation thing work properly. And the Bs, especially B6 and folate, are required to produce dopamine. And then you layer the tyrosine and mucuna on and you got a protocol. So this is very common. I'm gonna say it one more time, low dopamine with low glutathione or anything related to, environmental toxin protection. And I'll open it up for questions towards the end. So you guys, if you have questions, please type them in. We'll save time at the last few minutes for questions, all right? Okay, so we got that. What can we talk about here? This is what I want to look at. So I'm going to skip around on the slides to just keep it lively. So here, phenylalanine. So let me show you this. You ready? Phenylalanine converts into tyrosine in your body. Your body is able to make this conversion. Some people can't do that. Some people will have adequate amounts of phenylalanine, but not enough tyrosine. That's a genetic issue. You could also have low tyrosine because you have a bad diet. You could have low tyrosine because you've been stressed for a long time and you burned it up. You could have low tyrosine because you have a gut problem, H. pylori, you're not absorbing amino acids and protein very well. You could have low tyrosine for a lot of different reasons. Tyrosine then converts into L-DOPA. Okay, and DOPA, again, you can buy in a supplement form that's called mucuna, and it's standardized, it'll say on the label, standardized as 15% L-DOPA or 5% L-DOPA or whatever, okay? That then converts into dopamine, norepinephrine, and epinephrine. And here's what we're actually measuring. We're measuring the homovanillate or homovanillinic acid, it's the same thing, and we're measuring the vanilmandellate or vanilmandelic acid, okay? We're measuring these metabolites. And for those of you that are really into nutrition, there are these enzymes, COMT, COMT, see that? And COMT, catechol O methyl transferase. What does that mean? Catechol, catechol means O, methyl, methylation, transferase, transferring. This is the transfer of methyl groups, right? This is how you break your dopamine down into homovanillinic acid using catechol O methyl transferase, COMT. It's a methylation process. That's your B6, B12, and folate right there to make this metabolite. Plus you use it over here to make the dopamine. Plus you use the same thing to make your glutathione, believe it or not. It's all the same nutrients. Crazy is that? I'm telling you, if a patient is low in B6 or B12 or folate, then everything I'm just talking about now could completely fall apart. The other marker is vanilmandelic acid. That's a byproduct of norepinephrine and epinephrine. But let's just stick with the dopamine thing for now, because it's too confusing to try to learn all these at the same time. The treatments for these other two are the same, okay? If you learn the dopamine treatments, you learn the other treatments as well. And let's see. Here's more on pathways, so you understand actually what's happening here. Same thing, but just in a different diagram, so you get another visual. Phenylalanine converts into tyrosine. You also make thyroid hormones from tyrosine. That's kind of an aside, you know. L-DOPA, B6 then converts it into dopamine. There's our B vitamin, converted by copper and vitamin C into norepinephrine, then converted by SAMe into epinephrine. And here's our lab markers, homovanillinic acid and vanilmandelic acid, HVA or VMA. And the cofactors that I talked about in the beginning, remember, there's our B6. I didn't mention these earlier, but copper and vitamin C are also required. And there's our SAMe, sulfur-related stuff, right? Got to have the cofactors or this whole thing doesn't work. We talked about glutathione already. You got to deal with it if it's low. It helps you clear out mercury and other neurotoxins. It's made from 3 different amino acids, glutamine, cysteine, and glycine. That's something you should memorize. If you don't have that off the top of your head, glutamate or glutamine, this should say glutamine, but glutamate, some people write it as glutamate. So glutamine, cysteine, and glycine, those are the 3 amino acids that allow you to make glutathione, okay? And when you look at labs, you see that they are low in some of those amino acids, and you know they have a problem. Folate, again, we talked a lot about related to methylation. You have to be able to methylate to make all this work. And then you have these enzymes. Okay, so I'm just going to spend a minute on this because it's kind of important. So in order to make dopamine, and let's forget about norepinephrine for now because it's too complicated. And it's the same pathways and it's the same solution, so I'm blocking that out. So in order to make dopamine, you need tyrosine. And tyrosine converts into L-DOPA using this enzyme, tyrosine hydroxylase. But this is a rate limiting step here, meaning that when your dopamine gets to a certain level and your catecholamines get to a certain level, there's this shutdown of this enzyme. And so that protects your body from any damage from excessive tyrosine. But it also limits the amount of dopamine that you can make from tyrosine. So again, tyrosine dosed 1,000 milligrams 3 times a day, that'll convert into dopamine. But if you start cranking it up higher and higher and higher, this enzyme starts to shut down, and so that additional tyrosine will not bring up dopamine. So it doesn't really work to just keep giving people more tyrosine because there's enzymes in the way. But remember L-DOPA? Remember that's the same thing as mucuna. So mucuna or L-DOPA is past this enzymatic step. So the more L-DOPA or mucuna you give, the more dopamine they make. There's no limiter there. Sky's the limit. You give 100 milligrams, you get 100 milligrams. You get 200 There's no enzyme to stop it. So it's more dangerous, to be honest, to work with because you really have to know what you're doing. But it's also way more effective because if the person has really low dopamine, you can bring it up as high as you need to. So again, tyrosine, you always start with, and it has a very positive effect on dopamine. But at a certain point, just increasing the tyrosine is not going to work because this enzyme is going to shut things down. The mucuna or L-DOPA is past that enzymatic step. So sky's the limit. Okay, so you always start with tyrosine 1,003 times a day. If that's not effective after a few weeks, you gingerly and carefully add in the mucuna, knowing that every milligram of mucuna that you give is going to be converting straight into dopamine, and there's no protection of the body to shut that down. It's incredibly effective though, so you don't want to be scared of it. You just want to be cautious, Oh, I have a slide on that. Look, there's no regulation of the amount of dopamine synthesized from mucuna. It just goes straight over. So it's good and bad. If you know what you're doing, it's good. If you don't know what you're doing, it's dangerous. You just be careful with your mucuna. There's the same thing, okay? Okay, so now here, where are we at time-wise? Okay, we're right on time. This is so good. So I'm going to look at some labs and we're going to design some programs in 1 minute. I'm just going to wrap up with the slides here, and then at the end we can do questions, okay? So type in your questions. I'll have time, whatever I have time to, I'll get to as many as I can. So now, let's see here, hang on a second. Yeah, there we go. Okay, so now, summary here. Poor detox pathways, lack of glutathione, which happens to a lot of people, due to environmental toxin exposure, due to other kinds of things, depletes our neuroprotection. Glutathione levels are down now. Maybe the person's also under a lot of stress. They're going through a divorce. I don't know, this could never happen, but maybe there was like a worldwide infection that affected all human beings and the whole planet, and everyone got kind of stressed. Maybe something like that, you know? Methylations may be a little bit off, on top of the glutathione being low. Now the toxins are building up even more. The production of catecholamines is even off even more because the breaking down of the catecholamines and the production of them all require the same B vitamins. Now the brain's not working right. The labs then show low dopamine, exhausted glutathione, poor methylation, low glycine, low cysteine. That's like the one that we just saw. And this is like a package deal. Usually people have this in it's not just one aspect of this that's happening. There's multiple aspects of it that are happening at the same time, okay? All right, so now, let's pull this up here. And, oh yes, so we are, because this is a mini-series, a mentorship mini-series, we know that we are about to start a mentorship program on the 16th. If you've been thinking about it, do it now, don't put it off. No one ever regrets taking this class. It's a year-long, extremely intense exposure into lab interpretation. You will laugh, you will cry, you will come out of the year being one of the best people in the industry at interpreting labs, okay? And I can say that handily because I talk to all the graduates at the end of the course and I watch the jobs that they get, the clinics they go to, and people just kick butt after the end of the year because they really understand how to deal with patients, how to design protocols, exactly what supplements to use and what dose, how to put things together like I'm trying to put together today. Low glutathione, check out the dopamine marker. Surprise, surprise, they're both off. What am I going to do? You know, just getting this stuff down, getting it to the point where it just becomes second nature. And you got to have some kind of clinical training or you're just never going to be any good at this. I had Dr. Timmons for 8 years. I moved into the basement of his house at one point. Not that I'm a stalker, but he had a free apartment and I was like, okay, I'll live there. And, you know, every night for years, we would look at my patient cases and he just taught me case after case. I had 5 years with Glenn Frieder in the clinic together, side by side, literally. He was in one room, I was in the other. Every patient, I'd just go out and say, Glenn, what do I do? And he would tell me. You got to have people like that in your life year after year that train you in how to do this work. Otherwise, you're not going to be very good. Okay, so tyrosine, let's start off with that. So like the patient that we just saw, and we'll look at some more labs, but I just want to show you what a protocol would look like. So to say you get a tyrosine in a 500 milligram capsule, and you give them breakfast, lunch, and dinner. Yes, you can do it with an empty stomach if you want. You would maybe, now after all this talk, B complex, right? That's gonna have your B6, it's gonna have your B12, it's gonna have your folate plus the other Bs. Give at least one of those a day. And then, oh, NAC, they make it in 900 milligram, which I like a lot. So around 3 grams a day of that. Why? Because we're trying to get the glutathione up and you need the cysteine to make the dopamine on top of that. You could add in glycine to it. I'll put glycine with a question mark. That may be a little overkill for some people, so you don't have to do that. You definitely need some kind of a multi-pack or multivitamin. I like the packs. Usually they have fish oil with them. So let's say you have a multi-pack in the mix as well. That would be your typical starting dopamine protocol based on what we just saw on that lab. Low homovanillinic and low glutathione. And you run this for, let's say it's a 3 to 6 month program, 4 to 6 months. After 2 to 3 weeks, evaluate it. If they're not getting any better after that amount of time, then I would add in, if not responsive, Mucuno. And there's 2 different Mucuno products. There's Dopa Boost from Designs for Health, and there's Dopa Plus from Pure Encapsulations. We don't really have to get time to get into detail on how they're different, but they're different. They both have mucuna in them, but they're different formulations, quite different. But you can use either of them. I usually use the Dopa Boost just because it's stronger in some ways, but the Dopa Boost is more broad spectrum. I guess that's the difference between them. So you use those. This would be if they're non-responsive. Now you've added in that mucuna. Remember, it's past that enzymatic step, so now you're really going to bring up dopamine. It's the exact same treatments for epinephrine and norepinephrine. I'm not talking about them because it's confusing if every time I say dopamine, norepinephrine, and epinephrine. But it's the exact same treatment. So if you see the catecholamine markers, epinephrine and norepinephrine markers screwed up, exact same treatment, okay? Nothing different. Same. Why can I say that? Because look at the pathways. It's all the same. Here, yeah, right here, see, it's dopamine, norepinephrine, it's exactly the same. And you look at the more complex diagram, it's all the same, okay? Exactly the same, there's no difference, except for with this copper thing, but that's like something you don't really have to deal with, okay? All right, so let's take a look here at another lab. This is an OMX. This is from the Diagnostic Solutions Lab, which you all know as they do the GI map. And I'll show you on this one. Oh, this is such a beast of a test, you know. It really does take a year to teach this stuff, people, because it's complicated. But here, and to answer Michelle's questions, how many times a year do you offer the mentorship program? We'll have it now in September. There'll be one final one for the year in November, and then we'll start up again in the new year. So it's usually either 3 or 4 starts per year, okay? And I'm 60 years old now, so don't wait too long, you know? I'm not implying I'm gonna die. I'm just applying, I'm gonna ascend, you know, to some other plane or something, you know, and I'll be in Costa Rica living on the beach, surfing or something before things are too far along. Here, let's see. All right, so here, tyrosine, low. Homovanillinic acid, remember, that's the dopamine metabolite, undetectable. Bingo. Exactly the protocol I just wrote out is exactly what you would do. So now, for those of you that are thinking, you're thinking, here, you're thinking, oh, but wait a minute, what he said about this whole, like, what you call it thing, detoxification thing. So let's find that section. Okay, here. And remember the amino acids that are related to all this? Thionine, low. Homocysteine, these are all high. These are really screwed up. Taurine is up there. Cysteine, this is the one that probably the most interested in, is low. So again, we're right back to what I said in the very beginning. If you give the N-acetylcysteine to boost up the cysteine or cysteine, they're basically interchangeable, to boost up the cysteine or cysteine levels, then you're going to get that marker corrected for. That's going to help with detoxification. It's also going to help with production of dopamine. Methionine is the same. You'd probably want to also give this patient 2,000 of 3,000 of methionine, along with a 2,000 or 3,000 of N-acetylcysteine. And you're going to see this pattern frequently in these labs. Problems with glutathione, problems with sulfur amino acids. Remember, we make glutathione from glutamine, cysteine, and glycine, okay? There's a whole slide on that if you forgot. I can go back to it. Oh, look at this one. Glutamine is also low. Well, that's convenient, isn't it? So cysteine is low, glutamine is low. I don't know if we should hunt around for glycine in here. Where the heck is glycine? Probably doesn't matter. But anyways, point is, right, you got to memorize that. Glycine, glutamine, and cysteine are the 3 amino acids that help you make glutathione. So if glycine cysteine or glutamine are low, you should think about replacing them because that's how you're going to bring up the person's glutathione. Why do you want to do that? Because that's how you're going to protect your brain. All right, let's see. Let's look at one more set of labs, then I can do some questions. Did we look at this one yet? I don't think so. All right, well, let's make this harder. Let's start here. But really, we're just looking at 3 of the amino acids. Glycine is low. So right away, you're thinking, that's one of the 3 that I memorized on September 5th at Dr. Kalish's class, and that's one of the ones you need for glutathione. So right away, you're like, this is suspicious that they're low in glutathione. And then you're like, I can't really remember what the other ones are, so you go look it up, and it's glutamine. That one's okay. And then cysteine. That one's okay. Okay, well, that's not bad. Tyrosine itself is all right. Okay, so you're thinking, all right, that's a little bit going on there. For sure, I want to give them glycine. Do you want to give them glycine? Absolutely. Why? Because glycine's low, and you need glycine to make glutathione. So how much of it? 3,000 milligrams a day of glycine. Oh, and see, here we are. Glutathione is low. All right, well, now you're like, okay, it's coming together. You could give them glutathione also. Could you give them glutathione instead of glycine? No, but you could give them glutathione and glycine. Yeah, that's fine. You do both. Why not the one? Because they are low in glycine. You got to give glycine. Oh, and then in this particular one, the homovanillinic is a little low, and the vanilmandelic is kind of in the normal range. But they have a huge problem with serotonin over here. Okay, 5-HIAA is extremely high, and the dopamine marker is a little bit low. So they need all that dopamine support that we've been talking about, but there's clearly something going on with their serotonin. So that serotonin marker can go high if the person's on an SSRI. Then it's normal for it to be high. It's a normal response to those types of drugs. Or we had a case like this yesterday in the mentorship. If you were in the mentorship, you will learn this yesterday, which is that the patient was on 5-HTP. Okay, so 5-HTP can raise this up. SSRIs can raise this up. So now you have to kind of dig into the case a little more and see if they were taking an antidepressant when they did the test. Then this is just a normal finding for someone who's on an antidepressant. Okay. And let's look at another omics here. Again, this is a DSL lab. Let's find the section on the brain. Here we go. Oh, now we have homovanillinic acid, and it's high. Now let's peek around and see what's happening with the detox markers. I never find those on here. Let's see. Went the wrong way, sorry. It's right up here, I think. Yeah, here we go. Jing, 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 jing. Yeah, so there's several, we didn't talk about these yet, but I'll just mention this and then we're going to stop because it's a little overwhelming probably. The cysteine/cysteine is low. Remember, glycine, cysteine, glutamine, that's how you make glutathione. So you have to give NAC or cysteine to bring this up. How much? 3,000 a day. Alpha hydroxybutyric acid and pyroglutamic acid are both indicators of, does anybody know? Somebody type it in if you know. They're both indicators of, yes, thank you, Gordana. Thank you, Julie. Glutathione deficiency or toxicity. You could look at it's the same thing, right? So these markers, alpha hydroxybutyric and pyroglutamic, if they go high, it means that there's a glutathione deficiency, or you could say that there's a toxin problem. It's kind of saying the same thing with different words. And then if you look at this lab, if you guys are doing more Genova testing, let me just show you where these are because you got to be able to find these and it's not obvious. So the glutathione marker That first one is here, alpha hydroxybutyric. In fact, this patient is high. That's low glutathione. It's hard to remember because it's in the carb marker section, which is weird. Here's your pyroglutamic, which is high. Okay. Voila. Let's go here. Let's do this. Let's talk about what's coming up, which is the mentorship. We want you to sign up for this class. We want you to be at the Kalish Institute with another group of doctors for a year, spending several hours a week, maybe several hours a day if you're really into it, learning how to do these labs. You only have to do this once in your life. Once you get these basic skills down, you can relax and do other things, patient training wise, but learning how to interpret the labs. And then, I was talking to some graduates that were just finishing up the class from last year, and apparently one of the things that they learn that's actually maybe for a lot of them more important than lab interpretation, which is surprising to me because I think of it as a lab interpretation class. It's more like patient management skills, because we talk a lot about how do you explain that to a patient. What if somebody says, I don't want to take DHEA? What do you tell them about it? And just like the logistics of getting through this with patient communicate, I guess you could call it patient communication skills, sort of patient management. That's really hard for a lot of practitioners to learn how to do. And I just picked it up through osmosis because I was in the same treatment room with Glenn Frieder for like 2 or 3 years before he set me loose on my own. I just followed him around with a clipboard. He would give me a clipboard. He didn't want me to write anything down. It was just so it looked like I was doing something. He would say, make it look like you're taking notes, Dan. I would just follow him around and watch him. And the same with Timmons, but Timmons had a phone practice. So I just had to be quiet and sit in the corner and listen. And I taped everything that Timmons did. And I would listen to these cassette tapes over and over again of all the patient consults. So it's just like learning through osmosis. That's kind of what it takes. And repetition is also very important. Um, how much experience do you need for the mentorship? That's from Carrie. 0. You just need enthusiasm. And you can contact the office. You can scan the QR code. You can talk to Jennifer, who's our salesperson. You can set up a call with me. If you're nervous about it, if you don't have any experience, we only want people in the class who it's a good fit for. So I'm happy to talk with you, and Jennifer is happy to talk to you to make sure that it's, going to work. And we have times on my schedule this week and next week to talk to you all. So Carrie, we'll set up a call, okay? Dietitians, we have a ton of dietitians. It's almost like, I don't know where they all came from, but we have a lot of dietitians all of a sudden right now. Oh, what's the difference between the level 1 certificate and the Kalish Institute mentorship? Well, it's mostly price. So the level 1, I think the whole level 1 is a year long, and it's around $5,000, somewhere around there, something like that. The mentorship is a year long, and it's more like 12 to 15,000 bucks, whatever. It's a lot. It's like 2 or 3 times more expensive. So the level 1 certification is for people that are just kind of checking out functional medicine, or people that just don't have a lot of money yet. Okay, if $5,000 is like your max capacity, then do the one, the level 1 class. And if you can afford to spend, more money, you can do these payment plans for the mentorship, and it's just a much more robust class. Okay, and some people do the one and then the other. Some people take level 1 and they go to the mentorship like a few years later. What about RNs? Yeah, we have a lot of RNs. So we have RNs. This is for Kyle. We have RNs. We have nurse practitioners. We have dietitians. We have personal trainers. We have a lot of medical docs, mostly medical doctors. We have chiropractors. We have acupuncturists, osteopaths. Those are the main groups. It's a pretty varied group of people. So like we could have one class that's got one of each of those in a mentorship group. It's pretty cool to see the sort of teamwork that comes out of that. Okay, so we got that. Let me see. Dietitians, yes. Carrie's all on board. Oh, thoughts on the Mosaic Diagnostics Oats test. So Mosaic Labs used to be Great Plains Lab, one of the classic companies. They've been around for a long time. People love their organic acids test. And the main doctor that teaches over there, Dr. Kurt Wohler, he was a Timmons follower when I was a Timmons follower. I used to refer a lot of my patients to Kurt, 25 years ago. and he teaches over at Mosaic, and you're not going to get a better teacher than Kurt, you know. So and he's got a specialty in autism, and has worked with autistic kids, you know, for 30 years, and he's just a world-leading expert at that. So if you want to work with autistic children, that's your main goal, you'd be much better off using Mosaic Labs and taking classes from Dr. Kurt Wohler over there, okay? Because I'm not an autism specialist. So yeah, if the the serotonin marker is high, you got to figure out if they're taking serotonin or they're taking an SSRI, then it's not something that you want to treat. But if they're not and it's high, you can use 5-HTP. How does dysbiosis impact the neurotransmitter markers on the OAT? Well, one of the main reasons for, well, let me show you, I have to show you on the lab here, hang on a second. One of the main reasons why people get brain problems in the first place is because they have inflammation coming from a gut problem. And there's a whole section for that here. So this section here is to help you know if the patient has inflammation. So if kynurenolic acid is high or quinolinic acid is high, you have neuroinflammation. Doesn't tell you where it's coming from, it just tells you it's there. But one of the leading causes of neuroinflammation is dysbiosis, parasitic infections, yeast overgrowth, gut problems. So gut inflammation in some patients will raise kynurenolic acid and quinolinic acid. And how do you know? Well, you have to do a gut test. So you do a stool test if you see those high, and then you know, oh, okay, well, they have a gut problem and it's causing neuroinflammation. Also, on these organic acids tests, you can also see the dysbiosis markers. Now, this one's kind of obvious. This is like not fair, so obvious. They have almost every dysbiosis marker high. So clearly they have a bad case of dysbiosis. They have neuroinflammation. It's probably related to the gut. Doesn't tell you if it is or not, but it's suspicious. The other main thing that could cause neuroinflammation would be, well, it could be a head injury, maybe something like that. So there's other things. But one of the main reasons why people develop neurotransmitter problems is because of their gut. Cyrex Labs, also a great lab company, Dr. Vojani. Dr. Vojani and my teacher, Dr. Timmons, were best friends. I mean, they would giggle together. I still have memories of this. So funny. These two old guys, you know, I was like 30 and they were probably both in their 50s. So they seemed like really old men to me, you know, and they would go off in the corner and look at labs and talk about labs and giggle and laugh. And they just had the greatest time together. So these are the people that founded our field, you know, they developed all these tests. And Dr. Vojani, back in those days, he had a lab in Beverly Hills called Immunosciences. He left California, he opened a new lab called Cyrex. And so he's one of the great visionary leaders of our industry. He's like Richard Lord, my teacher, Richard Lord. He's at that level. So Cyrex Labs is amazing. And I got to do a call out too. There's a new company that I'm just working with now, and they are going to be the next superstars. You can kind of tell. I'm sort of a talent scout. I pride myself on being able to see who in our industry is just going to be amazing. And it's a company called Vibrant Labs. So if you're not using Vibrant yet, you should check their stuff out. Everyone there is so damn smart and they've got such great tests coming out and they're really pushing the edge. It's like Vojani and Timmons in the 90s when they would just be giggling and laughing and saying, yeah, let's do this test. Let's do this one test here. Let's invent another panel over there. Vibrant Labs has that energy now. They're just younger people, I don't know, not super young. They're probably in their 30s and 40s, and they're just going for it. They're just like, let's just get some new technology. Let's revive this functional medicine lab industry. So Vibrant is a great company too. Okay. So let's see. You can always give glutathione. Absolutely. Okay. You can always give glutathione. Absolutely. However, if the person's low in glycine and low in cysteine, you have to give those nutrients, and then you can also give glutathione. Or you can just give those nutrients in a higher dose to boost the glutathione. But in any of these cases that we're talking about, you can absolutely just use glutathione on its own. And you know, glutathione, oh, can you just give all amino acids? Not really, because you're trying to get a specific effect here. So if you really want to crank up glutathione, you need 3 grams of NAC and maybe an additional 3 grams of glycine to make that happen. So if you use a combination formula, you're never going to get enough of those specific amino acids high enough. But combination amino acids are used for other purposes, are really helpful too. You have to, yes, so for Rebecca, the answer is yes, liposomal glutathione is really the only way to go. All the students in my mentorship are really into quicksilver glutathione. I've never tasted it personally, but they tell me that it's the one that tastes the best. So the brand Quicksilver, if you're looking for liposomal glutathione, seems to be the best, very well absorbed, well designed, and it doesn't taste bad like many of the other brands do. How do you see low glycine and cysteine on a mosaic test? You can't, because the glycine and cysteine are done from plasma. Let me emphasize plasma, a blood test, amino acids, and the mosaic test is urine only. Okay. And you want to differentiate in your brain between plasma or blood-based amino acids and urinary amino acids. It's confusing and they're different. Obviously, what's circulating in your blood is quite a bit different from what you're dumping out. And the preferred way to measure amino acids, everyone pretty much agrees, is with blood, not with urine. If someone reacts negatively to glutathione, yeah, then you go back to the NAC and glycine idea, okay? So if the person has got normal levels of NAC and normal levels of glycine, you can still give NAC and glycine to boost glutathione, okay? So you don't have to have a deficiency of them to use them. That's an important thing. If you're in a deficiency state and the test shows you're low in glycine and cysteine, then of course you have to just get the person back up to normal. But even if their cysteine and glycine levels are normal on the test, you can still use them if they're low in glutathione. That's going to bring their glutathione levels up. So you're doing two different things here. One is replacing a nutrient that's missing. The other is using the same nutrient to boost another nutrient, in this case using NAC to boost glycine. I don't know much about pregnancy and nursing, so I don't want to comment on that. What about SNPs? Yeah, well, SNPs, well, we have like about 30 seconds left. So SNPs are very important. You can layer the genetic testing on top of what we're talking about here, and that's kind of an advanced level. So for Katie, I think it's a great idea. If they have a SNP in a given area and you see the problem on the lab, it's likely that they're going to need a higher dose than a typical person would, and they're probably going to need it for a longer period of time. But that's not necessarily a given. Okay? So glycine can make people a little like, ooh, tired. So N-acetylcysteine never has that problem. So you can probably switch people over. If they're having glycine reactions, you probably switch them over. So the metabolomics test is urine only, and that's where I teach in my mentorship class. The more advanced testing, including blood work, as a NutrEval, I usually recommend people save that after they've done my 1-year mentorship. Then we get into NutrEvals. But for that first year of training, I always recommend that people do metabolomics only, okay? It's enough to keep you pretty busy. Hey, great questions, you guys. I'm sorry I have to leave now because I could go on for hours. If you're not in the mentorship yet, by the way, I see a bunch of mentorship students here. Thank you, everybody. Good to see you, Shell, and other people. Lynn and Shell, there's a ton of you. If you're not in the mentorship yet, think about signing up. Reach out to my office. Let's get a call going, and I'll talk to you guys at the next one. Bye now.